Hello everyone, welcome to week 8 lecture. This is Mrs. Korea. We will be discussing about nursing care of normal newborn and nursing care of high risk newborn. With this, we will be finishing module 4 and module 3 and 4 are for your next exam. Please keep up with reading to make it easy for your exams, and I love seeing good grades. You need to read and study hard. Topics included in this week are nursing care of newborn, which includes APGAR score, newborn assessment including vital signs measurements, gestational assessment, and assessment by system approach, newborn reflexes, and nursing care of high risk newborn. There are so many topics, but I would like you to focus on hypoglycemia, meconium aspiration, respiratory distress syndrome, and jaundice. I have more details in my PowerPoint. Those topics I will not be asking many questions, but you need to read in detail and study on hypoglycemia, meconium aspiration, respiratory distress syndrome, and jaundice. On the other topics which I have mentioned in the PowerPoint, you will get only very few questions. Not every slide will be discussed with audio. I would like you to watch the videos posted under the videos because those are really good ones and you can get a lot of points from there, easy to understand, and if you listen to that you can get some good number of questions correct. And immediate neonatal assessment includes establishing airway, which means suction in that if it is needed, thermoregulation, heat loss by evaporation, conduction, convection, and radiation. I want you to read from chapter 17. This is a common question I have seen in NCLEX. So just keep attention when you're reading. Providing warmth, you need to dry the infant, place mother's abdomen, place baby on mother's abdomen and provide heated blankets, place beneath the radiant heater, and provide a cap. This is to prevent heat loss. We need to observe respiratory effort, color, muscle tone, stimulate the neonate to breathe deeply and cry, assess for heart rate, temperature, note obvious abnormalities, and check and record the number of umbilical cord vessels. How many arteries and vein? There are 2 arteries and 1 vein. The APGAR score we have discussed during the first day of clinical, and also it is available under the video, the first 10 minutes assessment. So please watch that too. There are 5 categories in this APGAR score. Each score 0 to 2, which are respiratory effort, heart rate, muscle tone, reflex irritability, and skin color. Your book has APGAR scoring system, which is the same which I have given here. Only little difference I have put it here is for the grimace or the reflex irritability, in that for 2 points, active motion, that is sneeze, cough, pulls away, and I believe in your book it says for 2 points under grimace, vigorous cry, which is also correct, but I think this is what I use mostly, and I have seen as a commonly used chart. Probably active emotion, pulse away, sneeze, all that can all that can go under reflex irritability. And also vigorous, if the baby is crying vigorously, that also can be considered the same as score 2 for reflex irritability. Immediate nursing care of newborn. The mother-infant identification is very important. We need to have identification band which is matching with baby. It should be there during the whole hospital stay. And whenever you take the baby to nursery or bring the baby back, always identify the baby's ID band with the mom. Then only give baby to the mom, because you don't want to bring a wrong baby to the wrong mom. Then injection and injury prevention, we need to give eye prophylaxis and vitamin K injections, and I would like you to find an answer why we have to give that. You most probably you know it. I want you to know that. The hepatitis B vaccine, we always need parental consent before giving. We can give it either at the hospital or during the first pediatrician's visit. Measurements and determination of gestational age. The weight is 2500 to 4300 grams is the normal. Length normal is 45 to 55 centimeters. Head circumference is 33 to 38 centimeters, and it is significant to measure up to 36 months. It has a significance because we can detect congenital hydrocephalus or an acquired one later in the infancy or toddlerhood. So serial measurement and recording carefully is very, very important. I recently had a patient which the primary care physician failed to notice the significant increase in the head circumference, and finally the child was very symptomatic and transferred to the hospital and diagnosed with severe congenital hydrocephalus, and he had a huge cyst in the brain. So what I'm trying to say is that all these measurements are very, very important, and plotting them on the graph and comparing from the previous reading to the next reading with each visit is very important. And the chest circumference normal number is 30.5 to 33 centimeters, and at birth head circumference is larger than the chest circumference. And what age head circumference and chest circumference are equal? By 1 year of age. And after 1 year, the chest circumference gets larger than the head circumference. And we need to record abdominal circumference too, and perform a Bellard gestational age by maturity rating scale. This is the Bellard gestational age assessment tool, and I usually ask maybe 1 or 2 questions from this, so please read this carefully, and also watch the video which I have posted, which explains very well how to do them. So go on to the videos and watch this video. Please don't forget to watch it. Assessment of the neonate by system approach. I want you to watch these 2 videos. The first one is assessment of newborn, the first 10 minutes. And the second one is assessment of the newborn, the head to toe assessment. We have watched both these videos during our first day of clinical. Please watch it again. And I have some details in my regular PowerPoint. These videos are really going to help you in understanding, and it is very easy to understand. I want to mention 2 things from this slide. One is milia. They are small white papules or sebaceous cysts on the infant's face. You may see on the face, nose, forehead, and the counterpart in the mouth is Epstein pearls. I don't think it is mentioned in your book, but these are the same sebaceous cyst in the mouth, which is called Epstein pearls. So we call it the Epstein pearls are the counterpart of milia in the mouth. And another thing I wanted to mention a little bit is cafe au lait spots or cafe au lait marks. They are little dark brownish spots. Most people may have 1 or 2 or 3 of them, but we have to remember if there are 5 or more of cafe au lait spots or marks, we have to suspect a condition called neurofibromatosis. So this is some knowledge in the practical world. I just wanted to give you that. I want you to know how to differentiate caput succedaneum and cephalhematoma. Caput succedaneum it crosses the suture line, and cephalhematoma does not cross suture line. In cephalhematoma, it is just one side. It stays in one side, but when you see the caput, it crosses the suture lines, and so that is how you need to differentiate it. When you examine the abdomen, always look for the umbilical cord. There could be a possibility of umbilical hernia. Then another point I want to tell you is about diastasis rectus, which is you may see on the abdomen like a bulging portion. So that is the abdominis rectus muscle, which is not fused completely. So it just separates, and that is why you may feel it is protruding, even when the child is training too. So my practical world experience is that some people may mistake the visible diastasis rectus with an umbilical hernia. Those two are totally different. So umbilical hernia you will see more on the umbilical cord, and this diastasis rectus you will see starting from umbilical cord and up. Those are a little more bigger. Just, if you ever happen to see them, I just want you to remember that. This slide is from the musculoskeletal assessment. We need to assess for torticollis. This is to check whether the neck has full rotation. So you may see some children or infants, they may prefer to be on one side, and this is, you need to assess if they are lying down. You make a noise on the other side, and if they have any difficulty in moving towards the other side, then there is a problem. So like it can happen along with when we went back on the sleeping on the back on baby, putting the babies to sleep on the back only, they tend to get the plagiocephaly, that is the flat-headedness, and also you may see a lot of torticollis cases too. So what initially, if you see that, we teach the mom about stretching exercises. So if they prefer to one side, try to put them on the other side, and like so that they can always try to look on the other side and stimulate from the other side. And another thing is developmental dysplasia of the hip. You have to assess for any asymmetry of the hip folds. That could be a sign that there is developmental dysplasia of the hip. Then two other tests we do is Barlow's maneuver and Ortolani's maneuver. So in the Barlow's maneuver, you are flexing the knees almost like a 90 degree, and you will apply pressure down on the humerus and to dislodge the humerus from the acetabulum. And if you hear a clank sound, then it is positive sign. And on the other hand, the Ortolani maneuver, in that you will flex the knees and then try to one at a time rotate the hip, and then if you hear a click, then its sign is positive and you will suspect developmental dysplasia of the hip. And look for any crepitus, unusual position of the foot like talipes equinovarus, or otherwise it is called club foot. Under the neurologic system assessment, we need to assess the reflexes. The Babinski reflex, Moro reflex, and Gallant and Gag reflex are the major reflexes, and minor reflexes are palmar grasp, plantar grasp, rooting and sucking, head writing and stepping, and tonic neck. The Moro reflex should disappear by 3 to 4 months, and if there is a weak or absent Moro reflex, then you should consider a central nervous system problem or CNS injury. And prolonged Moro reflex, that is, if it is still present more after 4 months, then you suspect cerebral palsy. And all these reflexes you will see in infants, and we call it this reflexes present or absent. It is not negative or positive. And the Babinski is also the same. Babinski can be present up to 2 to 3 years. Then after that, if it is present, then there is a CNS problem. Let us move on to the nursing care of newborn who are at high risk now. Hypoglycemia. When the blood sugar in a newborn is below 40 milligrams per deciliter, it is called hypoglycemia. Again, this number varies from hospitals to hospitals. Some hospitals follow less than 50, some hospitals follow less than 40. But the common used number is 40 milligram per deciliter. In the SGA, that is the small for gestational age and premature babies, the gluconeogenesis and ketogenesis are underdeveloped, and the glucose levels rapidly fall after birth. And in the infants of diabetic mother, high maternal glucose stimulates fetal pancreas to produce insulin. So after birth, the pancreas is still secreting insulin, and so that there is a hyperinsulinemia, while the maternal glucose no longer available, and then this leads to hypoglycemia. This can occur rapidly in newborns. Newborns at risk for hypoglycemia are SGA babies, preterm babies, large for gestational age newborns, stressed newborns, newborns of mothers of diabetic mother, and newborns who are poor feeders. Signs and symptoms of hypoglycemia are lethargy, jitteriness, poor feeding, cyanosis, apneic episodes, tachycardia, high-pitched or weak cry, eye rolling, and in case of severe hypoglycemia, you may see seizures, and prolonged hypoglycemia can produce neurological damage. So that is why we need to pay real attention to this, because when dropping, this can happen quickly and it can cause neurological damage. So you don't want to see repeated numbers below 30, then you have to do some interventions. Nursing care of hypoglycemia. The testing is done by heel stick. Monitor blood glucose on high-risk children, which I have mentioned in the previous slide. Follow hospital protocol on how often to check blood sugar. Each hospital may have little changes, but most of them, they base it on the recommendations by American Academy of Pediatrics. The feeding breast or formula is the first approach in hypoglycemia, and recheck glucose in 30 minutes. And if hypoglycemia does not resolve with feeding, IV fluids like D10% with water, push, and continuous infusion of IV fluids with dextrose 10%. And we need to continuously monitor the blood glucose. The first few hours may be hourly, then and if it is stable above 60, probably we may do every 3 hourly. The immediate management with the dextrose 10% push is usually done with 2.2 mL per kilogram. And the frequent feedings to prevent future occurrence should be encouraged. Prematurity classified by weeks of gestation. Severe prematurity, birth at 23 to 26 weeks of gestation. Moderate prematurity, birth at 26 to 34 weeks. And late preterm, birth at 34 to 37 weeks gestation. Conditions affecting premature newborn. They are respiratory distress syndrome, apnea, bronchopulmonary dysplasia, jaundice, anemia, necrotizing enterocolitis, gastroesophageal reflux disease, retinopathy of prematurity, and acute intracranial hemorrhage. I have briefly described all these conditions in my other PowerPoint, and we will be discussing, we need to focus more on respiratory distress syndrome and jaundice. Respiratory distress syndrome, it is a developmental respiratory disorder and affects preterm newborns. which occurs due to lack of lung surfactant. The signs and symptoms include expiratory grunting, nasal flaring, cyanosis in room air, tachypnea, labored breathing with retractions, and decreased breath sounds, often with rales. The surfactant actually lowers the minimum surface tension and increases pulmonary compliance and oxygenation in preterm newborns. Management of respiratory distress syndrome. Airway maintenance and oxygenation are the priority interventions for the newborn with respiratory distress syndrome. Then administration of artificial surfactant, example Survenda. This is to reduce the surface tension. And this is commonly used in preterm infants. The types of oxygen therapy includes humidified oxygen, continuous positive airway pressure, otherwise known as CPAP, then conventional mechanical ventilation, high frequency oscillating ventilation, you call it as HFOV, then high frequency jet ventilation, that is one more level up of the previous one, then nitric oxide treatment for patients with subsequent persistent pulmonary hypertension, extracorporeal membrane oxygenation or ECMO, as is used in worst case of respiratory distress syndrome. The ECMO is done only in level 4 NICUs, not in level 2 or level 3 NICUs. The next topic is jaundice. Physiologic jaundice is otherwise known as hyperbilirubinemia, occurs because newborn's immature liver cannot conjugate bilirubin as quickly as needed. The signs and symptoms are visible jaundice, which is yellowish discoloration, is seen at a level of 5 mg per deciliter within first 24 hours of birth. The diagnosis of hyperbilirubinemia is done by serum bilirubin level. If it is rising faster than 5 mg per deciliter in 24 hours, then you would consider there is neonatal jaundice. And the direct bilirubin, if it is more than 2 mg per deciliter, and it would be lower than that of a full-term neonate, and level of concern varies with gestational age and postnatal age in hours. So the next chart will explain that. Look at this chart. So depends upon the postnatal age and also the gestational age of the baby too. There is a different chart for that. I don't want you to learn in depth on this, but I just want you to understand that it depends upon the postnatal age and the serum bilirubin level. So for example, if the child is 48 hours of age and if it is the bilirubin level is 8, it is still on the lower risk. But whereas if the child is at 12 hours of age and if the bilirubin is 8, it is high risk zone. So just look at it and understand. So as the age goes up, even if the bilirubin level is high, like 8, 10, 12, depends upon the age, it may not be in the high risk zone. Prevention of jaundice is frequent and early feedings, breastfeeding or formula feeding, whatever the parents choose. Nursing care involves the newborns in high risk zone on bilirubin risk chart undergo phototherapy, which is basically the light therapy. So during phototherapy, the newborn's eyes must be shielded by an opaque mask and assess the eyes for discharge or corneal irritation, and also remove the mask during feedings so the newborn can receive visual stimulation. Also, we need to cover newborn's genitalia to cause any damage to especially on the male children, because that can cause sterility. Then hydrate with electrolyte solution if needed. Severe jaundice, if it is not detected early and if not managed properly, that can lead to some complications such as bilirubin encephalopathy and kernicterus. And if there are some certain high level of bilirubin, and then we cannot just manage with phototherapy, we may have to do another intervention called exchange transfusion. This is a picture, of exchange transfusion. So which you take out the blood and push back blood. So, and this is how you try to remove the extra bilirubin from the system. Meconium aspiration syndrome. This is more common among post-mature babies. It occurs when the newborn is delivered through meconium-stained amniotic fluid. The signs and symptoms are meconium-stained skin, nails, and umbilical cord, initial respiratory distress, barrel-shaped chest from overinflated lungs, rales and rhonchi heard on auscultation. So this is an important thing which I have already told you during some of the clinicals. So whenever a baby is about to born or the water is broken, we always ask, is the water clear or no? If they say meconium, if it is meconium stain, then we have to make a setup with a meconium aspirator and all that, which I have shown to some of you in the clinical. So with meconium stained amniotic fluid, if the baby comes out vigorous, means baby comes out crying, it is okay to do the regular care like drying the child. But if the child comes out floppy, then we should not stimulate the child. No drying, no stimulating the child. We need to suction the baby, and if there is a neonatologist present, use laryngeal suction by intubating the baby and using meconium aspirator. Then only you will dry the baby, because if you don't suction out all that meconium which stays in the larynx and the trachea, so with the first breath, the whole meconium will get aspirated into the lungs. So then it is called meconium aspiration syndrome, which you want to avoid. That is why you don't stimulate if the baby comes out floppy. Just, it's a practical point. I just want you to keep that in your mind. The diagnosis of meconium aspiration syndrome is done by a chest X-ray that shows bilateral diffuse opacities with areas of atelectasis and hyperinflation from trapped air. And the management involves chest physiotherapy, oxygen administration via CPAP, or medications such as Pavilon or Norcuron used to increase the effectiveness of ventilator effort. Analgesics and sedatives medications are also used, such as fentanyl and lorazepam. Morphine sulfate or meperidine, demerol, all that is used to prevent newborn from fighting from the ventilator, because if the baby is on the ventilator, you want to reduce the stimulation, and you don't want the baby to be fighting against the ventilator. So that comes to the end of week 8 lecture and end of module 4. Again, please keep up with your reading, and that is going to help you out a lot. And thank you for listening.